Thank you, Dr. Claude. And right on cue, could you just help Dr. Legodi, please? We have Dr. Legodi, who is going to be discussing Legodi. Thank you, Doc. It's going to be discussing red eye, which we all at GEMS have after our CHO speech. But in the meantime, let me introduce him. He graduated from Medunza in 1996, and after his internship at Swallow Hospital, he worked as a medical officer at Voortrekker Hospital, and then joined the ophthalmology residency program from 1999 to July 2003 at Nelson Mandela Medical School under Professor Ann Peters. He's currently working at Mpudule. Do I have that right? Eye Centre in Pretoria. He was also involved in sessional work at Pretoria Academic Hospital, now known as Steve Biko, in teaching and training retina specialists. Next to his medical practice, Dr. Legodi is involved locally in many positions as part of his active role to improve the ophthalmology service in South Africa and Africa. He's the first Black immediate past president of Ophthalmology Society of South Africa, and first African World Ophthalmology Congress 2020 president, member of South African Vitreoretinal Society, chair of SPPC of South African Medical Association, and former councillor of College of Medicine in South Africa. Dr. Legodi is married to Dr. Kgao and are blessed with 2 children. The first African to serve as American Academy Ophthalmology Trustee Board of Ophthalmology from 2016 to 2020 at large, and the Vice President of International Ophthalmology Council, President of the World Ophthalmology Congress 2020, whereby he played a big role in bringing the World Ophthalmology Congress for the first time in Africa, which will be hosted in Cape Town, or was hosted in Cape Town in 2020, and he's been inaugurated by former President Kgalema Motlanthe as first president of OSSA in 2013. Awards, HE, is that MR or Mr.? Mr. Mr. Jacob Zuma, president of SA, awarded him with Nelson Mandela Gold Award in 2013 and Trelawney 43 Recognition Award in Swaziland by the Deputy Prime Minister of Swaziland in 2013. Welcome, Doctor.
Thank you, Mel. You want to put us into trouble. MR Jacob Zuma. For us, MR is something else. Huh? Good morning, everybody. And I'd like to say thank you to the GEMS for inviting me, and also to my colleagues, doctors who are here, who just woke up early in the morning to come and listen to me. And I would like to say to Dr. Claude, we doctors, we are here to serve your clients in dignity, ethically right, and we'll do our best to do our best. Today, I'd like to ask to talk about the red eye. Red eye can mean a lot of things, and let's talk about it. I had Mel here, she said, I'm going to talk about sharpening the vision. Unfortunately, today I'm going to tell you about sharpening your knowledge, how to treat a patient with a red eye. A red eye is just injection of the superficial visible vessels of the conjunctiva. I hope you still remember your anatomy of, of the eye, which you attended only for 2 weeks. And looking at the audience here, I can see some people are really older than me, and I hope they still remember. This diagram, for me, it's very important so that you can know what does it mean. Me, as an ophthalmologist, a red eye can mean a lot of things. You've got a conjunctival red eye, and it tells me what can be the cause of it. We can have a mixed red eye, which can be a corneal disorders with interocular irritation and corneal ulceration. And those diagrams, those pictures, if you can see, they differ. If you look here, you can see the vessels, the way they look. Look this side, the vessels more on the limbal side, and this side here on the, next to the sclera is more dilated vessels, and ciliary flash here. This diagram, it's extremely important for us. Now, let's start with those direct ophthalmoscopes that you've put in your rooms and they're getting dust. That thing on the red ophthalmologist, this is a blue light, there's a green light, there's a white light. And the green light can help you in so many things. It's so simple. You just take it out from what in your room, just switch on the green light, and after switching on the light, see on the patient, you can see a lot of pathology just by me doing that. Remember that. Just change the battery, put it in, and start doing it. Then you can see on the green light, the vessels are dilated. If there's a tortuous vessel, you're going to see it. If there's something on the cornea, you're going to see it. Like this patient, look around here. There's some dots, meaning that there's a problem with that direct ophthalmoscope, which is in your rooms. Now, what are the causes? It can be from allergy, it can be from infection, it can be from inflammation, it can also be from glaucoma. By the way, glaucoma is just high pressure of the eyes that can damage the optic nerve and is irreversible. Now, for me as an ophthalmologist, when a patient tells me the symptoms of the red eye, it must click in my mind, what does that mean? A blurry vision usually indicates a serious ocular disease. A severe pain may indicate keratitis, which is inflammation of the cornea, ulcers, corneal ulcers, iridocyclitis, which can be uveitis, or acute glaucoma. And for photophobia, whereby the patient is having a problem from the light, usually it's due to iritis because the pupil is opening and closing, and that causes pain. Exudation, typical of eyelid or conjunctival inflammation. Itchy, it can be allergy. Ciliary flash, most of the time is glaucoma. Conjunctival hyperemia, corneal opacification, corneal epithelial disruption, pupillar abnormalities, shallow anterior chamber. All those things, for me, they've got a meaning. For me, as an ophthalmologist, a shallow anterior chamber, I must think of glaucoma. Elevated intraocular pressure, glaucoma. Proptosis can be thyroid eye disease or something that is pushing at the back of the eye. Discharges, we'll talk about them. You can know that it's very important also. Preauricular lymph nodes, enlargement, also you have to check them. There's this diagram whereby it can illustrate. I wish you can just take this picture of this so that it can give you an idea. When follicles are the things that I'm going to show you later, which are on the eyelid. Once they are there, you must also go to this way. Do they have preauricular lymph nodes? If no, then think about something else. If yes, look for herpetic signs. Herpes simplex viruses or adenoviruses. Then you go to papillae. Papillae also, they are on the eyelids. If there's on the side of the discharges is the severe purulent, think of gonococcal. Scanty purulent, bacteria other than gonococcal, and watery, we know that most of the time is allergy. Now let's talk about allergic conjunctivitis. It can be allergic rhinoconjunctivitis, vernal keratoconjunctivitis. By the way, keratoconjunctivitis, kerato is the cornea, and also conjunctivitis. Therefore, inflammation caused by the allergy causing cornea and conjunctival problem. And we've got atopic keratoconjunctivitis. Atopic, just to do with the skin. Now, let's start with the allergic rhinoconjunctivitis, maybe seasonal or perennial, and most of the time it's chronic, and also it happens on the young children, but it can happen to anybody. Frequently associated with nasal symptoms like sinuses, hypersensitivity reaction to specific airborne antigens. And as I said, venereal keratoconjunctivitis is the one that we usually see. We usually say VKC when we shorten it, and usually recurrent and bilateral, affect children and young adults, as I've already said. More commonly in males, I don't know why, it's so sexist, and in warm climates. Itching, mucous discharge, and lacrimation. And the types can be palpebral, means on the lid, limbal, on the limbal around the corneal side, or it can be mixed. Treatment, we usually give them topical mouth stabilizers like Relisted, they are there. Probably you know Specialage and the topical steroids, but in a minimal. Frequently associated with atopy, asthma, hay fever, and dermatitis. And the progression of venereal conjunctivitis can be a problem. Those things that I was talking about earlier on, it can cause about diffuse papillary hypertrophy, most marked on superior tarsal. If you look, we usually try to turn the upper eyelid, and you're going to see this area here, like cobblestone, like, well, they're still here, smaller. And as time goes by, they become ruptured and can be painful for some of the patients because they started to form some pus around it. Then on the limbal side, we usually have, we call it standard dots. Is these dots. You usually see them with your bare eyes when the child is there here in your rooms. Once you see that, please try to give steroids. We call it FML. You can also start with them before you refer the patient to the ophthalmologist. And as it progresses, now it's starting to affect the cornea. And as I said, yes, on that direct ophthalmoscope, you see, we use the blue light, we use the green light to see those punctate epitheliopathy, epithelial microerosions, and you go on and on. About atopic keratoconjunctivitis, also look at the lids around the eye. You see that most of the time eyelids are red, thickened, and macerated and fissured, and typically affects young patients with atopic dermatitis. And as it progresses, it can cause more problems. Can I just do something here? As you can see that on the inferior, they call semblepharon. Semblepharon is the scarring of the area between the cornea and the lids. And as time goes by, the patient is unable to move the eye up and down, and sometimes they can complain of double vision and can be painful. And that can be caused because we didn't treat the patient properly. And also to do with the inferior phonacial papillae. Then on the progression of atopic keratopathy, as we said, now it causes the cornea. Now, this is a problem. It's going to cause what we call corneal erosions, epilopathies, and at the end, scarring. And once it's formed the scarring, it means that the patient can no longer see very well. Then at the later stage, the result can be corneal graft, which can be very expensive. And as you know, our cultures here in South Africa or in Africa, we hardly donate parts. We have to get them from US, where just that one cornea, I'm sorry, Claude, it cost about 40K, one eye. Conjunctival infections, it can be either bacterial, viral, or chlamydia. Let me start with this bacterial thing. When we were a registrar in Natal, we used to see it on a regular basis, almost every day. Then the signs are there, You can look at the eyelids. They're crusted. They've got some pus on them. You look on the lower of the lids, you can see some discharges, mucopurulent discharges. And ladies and gentlemen, it's not nice. And if I can tell you the cause of it most of the time, when we're doing study there, is that most of the people, when they've got a red eye, they used to treat the eyes with urine. And those are the challenges that we used to see. Remember the urine, that person can have a gonococcal and it goes into the eye. And it's still there. When I arrived in Gauteng, there was, people who are learned, they will say that I was told by our traditional doctor to say that I must go and get a virgin monkey urine. How will you know that? Honestly, that day I looked at the man, is well respected. I said, I don't get it. A monkey, which is virgin, and we get the urine into the eye. Let's not go there. Then you see, as time goes by, this is the gonococcal keratoconjunctivitis, what it's doing. It causes acute profuse prurulent discharges, hyperemia, chemosis. This is havoc for me, because this eye is going to cause complication like corneal ulceration, which is going to burst, open the eye. The only solution is enucleation. We used to do them almost every week in the name of urine. Adenoviral conjunctivitis, these are the common things that you usually say, pink eye, pink eye. Pink eye is there, ladies and gentlemen. And when the patient's got it, don't undermine, wear gloves. Use tissues to put and throw them away. You as a doctor, you are too close to the patient. Please also take care of yourself. Wash all the instruments around it. And those are very important because it can be a problem. I'm not going to say all these things that I think you can read them, but those are the things that I need you to be aware of. Then at the later stage, you can see that the eye is very red, is very angry, as we usually say, and usually bilateral and is watery. Don't touch the patient a lot, please. And the symptomatic, unfortunately, is symptomatic, and avoid steroids. Did you hear me? Avoid steroids because you can make it worse. Sign of conjunctivitis, as it goes by, it can also go to the causes what we call focal keratitis, which is just small lesions on the cornea. And this one is when we can start with the steroid, but after the ophthalmologists have seen it. Molluscum, these days we don't usually see it on a regular basis, but also this one is also contagious, very. And we usually see it on the children, and usually it's that waxy umbilical eyelid nodule, may be multiple on both eyes. And we usually do distraction. Most of the time, this part of the eye is usually done by dermatologists just to do excision, cryo, or cautery. And if it's epilateral, it can be chronic mucodischarges and focal conjunctivitis. And with herpes simplex conjunctivitis, it usually happens on children with these discharges and the vesicles, and we usually give them topical antiviral treatment. And coming to adult chlamydial keratoconjunctivitis, this one used to be there then, but now we don't usually see it because it usually happens more on the north of Africa. And it's just to do with hygiene also. And it used to be a #1 killer of the vision. And lucky enough, we don't usually see it here at home. We just say, must I thank God for that, really? Because this is to be very bad for our patients. Neonatal chlamydial conjunctivitis between 5 and 19 days after birth. may be associated with otitis, rhinitis, and pneumonitis, and we usually treat it with topical tetracycline or oral erythromycin. And with the trachoma, the same, that we usually also more up there than here. And the infection with subtype A, B, BA, when I was registered, I don't know what I was thinking. I was just to say, what is this serotypes about? Why do I have to know them? But as time goes by, you learn that you have to know them so that you can treat the patient properly. And usually they start having this ocular follicular conjunctivitis and the scarring at the end of the entropion. Entropion means that the eyelid is going inside and rubbing the cornea, and it's painful. And these are the things sometimes that make the patient to have corneal scarring, and we have to end up doing corneal transplant. Coming to the sclera, as you know, there's a cornea, there's a conjunctiva, there's a sclera. And on the sclera, also, we've got part of we call episclera and sclera. And on the episclera, it can be the simple or nodular. And also with it, with that direct ophthalmoscope can help you to see which one it is, because it's going to be very easy to determine the layer. And usually these ones, especially the anterior scleritis or posterior scleritis, goes with the systemic diseases, which I'll explain to you just now. As I said, anatomy, look at the normal of the sclera, episclera, and scleritis. And usually this part is just that I cannot go back and show you with that green light how can you see it in the layers. But with the practice, you'll notice it better. You see here, a simple episcleritis. Sometimes what we do, there's a small drop. We call it epinephrine eye drop. You can put a drop of it there. It blanches the episcleritis, but it won't blanch the scleritis. The other time that you can also know which one is scleritis and which one is episcleritis. And usually typically affects young adults, seldom associated with systemic disorder, the episcleritis. Treatment, topical steroids. And this is nodular episcleritis. And the causes of this systemic association of scleritis can be rheumatoid arthritis is number one. We can have vaginous granulomatosis, polyarthritis nodosa, systemic lupus, and miscellaneous can be herpes zoster, relapsing, or surgically induced by us, unfortunately. Then with the diffuse anterior and non-necrotic scleritis, by the way, this scleritis, the reason why I'm giving you this lecture about it, yes, it's more on the side of the ophthalmology, but I need you to refer it quickly because this can affect the vision of the patient forever, because it goes on and on. It goes with the systemic problems. And those are the things that I like you to be aware of. And as it's called nodular, it goes on and becomes more serious than diffuse scleritis, and it can cause more problems. And the patient, by the way, is in pain. You see, as go by, it's starting to form the sclera, the iris, the choroid is starting to show off. And what is start to be like this part spread in coalescent, meaning that even for us as a surgeon, I have to be very careful when I operate this patient. Extremely, extremely careful. Then it can rupture on its own, unfortunately, and usually associated with rheumatoid arthritis. And please refer this type of patients. Don't sit down with them because it goes also to the posterior scleritis and it causes exudative detachment. This one. Then later, the choroid also, it becomes smaller and smaller, and the patient is blind for good. And when we do radiology, and that's what we see at the back of the eye. And those are the challenges that we have. And all in all, I'd like to say thank you.
Yes, you may. Thank you so much, Doctor. Takeaway is wash your hands and refer the red eyes, not the Monday morning red eyes. Dr. Legodi, we'll open the floor for, if you don't mind, if there's any questions, please. Any questions from the floor? Anyone with red eye after Friday night that would like doctor to have a look at your eye? Okay, doc, no referrals today. Thank you. Oh, there's one.
We don't know the reason. It's not the only one medication. Sometimes we give, rather give Toprex. There's a Toprex ointment that's antibiotic. We don't know why there's another one, antiviral one. Which is family ointment. We still have a problem. And those drugs they used to help us a lot. Honestly. And we don't know why they stopped. It's not us.
Any other questions? Free consultation? Going once? Going twice? Is it a PMB?